Thanks for the reminder. Okay, so I will hand it over to Elizabeth. She is going to take us through a very interesting talk. I put the little agenda up in the chat. So Elizabeth will do her talk. We'll take about 5-minute break. Folks can just, get a sip of water or something. Come back, we'll do a Q&A. If you have questions throughout, please just throw them in the chat box and I'll compile them and we can put them to Elizabeth during the question period. So when we get to the question period, you are welcome to either unmute yourself, put yourself on video, or type into the chat box. Just a reminder that we're recording it. So if you don't want for for whatever reason, your name or your face to be shown, just know that you can change your name or don't put your video on when you ask a question because this will be recorded for everyone to see. So I will pass it over to you, Elizabeth. Thank you.
Great. Thank you so much, Jessica, and welcome everyone. I'm really excited to be in your virtual learning space today. This is a weird and wacky world that we are living in at the moment. My name is Elizabeth Mohler, and I've just started my PhD at Western University in the School of Rehab Science in the occupational science field. So occupational science looks at human participation and human occupation and how individuals engage with their environment and the interdisciplinary factors that impact how an individual engages with their environment. So very applicable to this talk and to this course. And my research, like Jessica said, focuses on the impact on adults with physical disabilities that accessing direct funded attendance services has on community engagement. So thank you for having me here today, and I'm really excited for the talk. So before identifying barriers to accessing healthcare, it's really important to first just unpack a little bit models of disability. And you might have heard about these in your other courses, or maybe you've read about them in these readings for this course. But the first model we really want to unpack is the medical model of disability. So the medical model of disability really looks at the person with the disability as the problem, and the disability as something that needs to be cured or treated. And I should pause here and say that absolutely, there's nothing wrong with saying, I live with a disability, and if there was a cure someday, I'd want that. But it's not necessarily that that's the problem. It's a belief or an attitude that individuals are inherently, quote unquote, needing to be cured or fixed. So when we see this word medical model, sometimes people think, oh, doctors. So certainly medical professionals can espouse to belief in the medical model, but it's a belief system that goes beyond medicine and healthcare. So it problematizes a disability within the individual. So it's about needing to be fixed or cured or treated, and really sits the disability within the person. And society really in this model has very little role in sort of fixing bigger systemic environmental problems or attitudes or systems or policies. So that's kind of the medical model of disability. The social model really underpins this idea of disability as a factor within the environment. So it is things within the environment that disable us as individuals rather than a disability being situated within ourselves. It's a political problem of society's barriers, and it places the responsibility within society for trying to fix, quote unquote, environmental barriers or problems. So it's really a political model, and it sees disability as neither good nor bad. It's a neutral characteristic or part of who we all are, just the way our gender or our race or ethnicity might be. Disability is kind of just a characteristic of who we are. So instead of trying to cure people of impairments, it places responsibility on society to get rid of barriers. And I have a really cool comparison that I like to use to help really distinguish medical versus social model. So somebody who uses a wheelchair goes into a restaurant and the door does not have a door opener, and the aisles are not wide, and a comment is made, your chair is too big, you're in the way. So it's problematizing the lack of access within the individual. The social model would say, hey, whoa, wait a minute. We need a door push button, because not only is that going to help you, this one person, it's going to help individuals with strollers or packages, or individuals who frankly don't want to open the door. They don't want to touch the door handle. And we need wider aisles to accommodate more people of differing needs. So again, that's a great example. It looks at the structure as opposed to the individual. The affirmative model. This is a kind of cool one because it sort of challenges view of impairment that we've seen in the media. You see those common tropes around impairment as negative. You might have seen the tropes around disability as victim, or the superhero, super crip. Affirmative challenges all that. It says, let's have pride in our disability. That doesn't mean to say that there aren't days where disability can be downright discouraging and frustrating, but let's have pride in our disability. Let's use disability culture. It's a part of normal life conditions. A great example of affirmative model is around reclaiming. So maybe you've seen art by disabled artists. They've reclaimed the word mad. They're very open and proud about the fact that they live with mental health challenges. They're using their art to portray their experiences. That would be an example of an affirmative model. Or deaf culture, and really embedding the disability into culture. So that's the affirmative model. And it's an ordinary aspect of the human experience. The rights-based model. So this one's kind of cool in that it says, well, hey, all persons should have accesses to resources in the community, and it's underpinned by the United Nations Convention on the Rights of Persons with Disabilities, which Canada signed in 2010. So it looks at access as a right. It's not a privilege to take part in community. We need structures that facilitate that right. So those are the 4 models of disability. I thought it'd be really helpful to go through this today. In terms of barriers to accessing healthcare, I want to say that there are many, many more than 4, but these are sort of the 4 main barriers that I've sort of grouped our talk into today. And I think that will kind of really help to frame the conversation. So the first is physical. So that's kind of obvious, right? You think about maybe there's no curb cuts, or you think about the door example I gave, or you think about stairs and no elevators. That's physical barriers to accessing health services, and I would even say community services. Attitudinal barriers. So that's kind of an unwillingness to accommodate. Sometimes it can be because of lack of knowledge or lack of know-how. Sometimes we just don't know how to make an accommodation, or attitudes can be based on myths, misconceptions, stereotypes, prejudices, all kinds of things. So that's an attitudinal barrier. Communication barriers. So this can be a lack of knowledge on the part of healthcare providers or other community social service supports, where communicating with people who maybe don't speak the way you and I do is a challenge. And so the barrier there is how to communicate with someone that maybe uses sign language or doesn't speak and uses an iPad. So that would be a communication type barrier. Another communication barrier would be, here is forms at a hospital you need to fill out in print, and you're someone that does not read print. So those are examples, and we'll get into all these, of communication barriers. Systemic barriers. So policies that systematically exclude, could exclude people with disabilities, those who are from a lower SES status, all kinds of ways that policies can be exclusive. So examples of barriers to healthcare, barriers to people with disabilities when accessing health. So poor communication between people with disabilities and physicians, leaving people with disabilities with unmet needs. So this isn't just about the communication barrier I talked about earlier. There was a recent, really interesting study done by the CCD, so Council of Canadians with Disabilities, that talked a little bit about the challenges that as a healthcare provider are had around knowledge of how to work with patients with disabilities. So you might be thinking, well, wait a minute, it seems to me that in healthcare, there should be knowledge of how to work with all kinds of people, and that's absolutely true. But people that come in with very specific needs, so for example, a woman with a physical disability coming into an obstetrics clinic who's pregnant, perhaps the doctor's never seen that before, doesn't know how to effectively provide information because they've never had a patient with those needs. So then those needs go unmet. So that would be kind of an example of that. Inadequate number of home care hours. So really what this means, maybe some of you have a loved one or friend who receives support at home. That could be through a nurse, it could be through a personal support worker, it could be through an attendant. So what we mean here when we say inadequate number of hours, going back to our systemic barrier or policy barrier, a lot of times there's restrictions on caps, so number of hours. So CCAC might have 4 hours a day, or direct funding might give you 6 hours a day. So direct funding means you hire your own support staff. So unmet needs from that might mean, well, I need more than 6 hours of support, but that's all I'm getting. So again, leaving people with unmet needs. And that would result in increased hospital stays. It's pretty obvious, right? If we're not getting support at home and our needs aren't being met, either from a health or a wellness perspective, we're going to probably wind up pretty quickly in hospital. So physical barriers, so we talked about this. So curbs or parking. Yes, Nicole, I will. Great, absolutely. Keep that one on the back burner. So parking, we think about the physical barrier of a curb at a hospital where somebody might not be able to get into the building, or a doctor's office. Hospitals are generally pretty good, but doctor's offices, I see lots of doctor's offices here in Toronto where I live with big old buildings with staircases. You see, just the other day, I was listening to something on CBC that talked about parking and the fact that for people with mobility issues, sometimes the parking costs are prohibitive to park in the hospital lot. So they're having to park quite a ways away. And then what's happening is you're having to walk quite a distance. And for some people, that's prohibitive. So then they don't go to get treatment because they can't afford parking, or they're not going to be able to walk. So that's certainly one. And some medical equipment, so mammographies or weight scales, doesn't accommodate wheelchairs. So if you think about maybe the last time you had the doctor, I've done this in a while, but you stand up on the scale and it weighs you. So if you think about somebody who can't get out of a wheelchair, or you think about somebody who's perhaps not able to use a mammography in the traditional way, those are barriers. And I point these out because what happens is, back to those unmet needs, folks aren't receiving treatment because they're not getting the services they need. But I always like to think about, well, what are some solutions, not just barriers. So COVID's taught us many things, and one of those is virtual visits. So we certainly can't do everything virtually, but the power of a virtual visit with a physician and patient has meant that people who can't go into an office can get services at home. There's great services through telehealth, so you can call and have an interview with a nurse. There's really cool video conferencing software. One that I'm aware of is called Doxy, where again, you can show a doctor some symptoms that are perhaps going on for you, and they can try to diagnose. It's certainly not the same. So those are certainly some workarounds. I think another piece that's really important with all these physical barriers is for doctors to be able, and other healthcare providers to be able to know and source out where stopgap, love it. Where are there, because that was actually my next solution, where are there clinics that are accessible? So again, in Toronto, where I'm situated, we've got one called Vibrant, and it's a great clinic. It specializes in working with people with a range of disabilities. So if you were a healthcare provider and your clinic wasn't accessible, just kind of having note of where there are clinics that folks can go to get those services. And someone's beat me to it, stopgap. So maybe you are a clinic in the community, you can connect with stopgap. If you've got, now this doesn't work for a whole flight of stairs, but if you had just a few steps, stopgap is a really great resource that for those who don't know, will actually come out and install a wooden ramp on top of a couple of steps going into a building so that folks can get into the building. Taking a swig of water here. So we talked about information barriers and communication barriers. Now, of course, this was pre-COVID. But a big barrier for me is that medical forms are predominantly in print. So if you think about the last time you went to a dentist or doctor, or you went to a community health center, you're probably given a long questionnaire to fill out with your whole life history. And they're predominantly in print. But one of the things that's been really great about COVID, because there are some silver linings, I believe, is that forms have been sent electronically to patients because we're not going into offices, which has meant that I don't need to give out my personal information to somebody to fill out the form for me. I can fill it out independently with the screen reader. The challenge with print forms is you either have to ask the person who's with you, and maybe you don't want them to know all your personal health info, or you have to ask someone there at the office. So it's a bit of a dignity thing. So again, that solution of being able to send things in advance is great. So even with the advance of info online, this was sort of pre-COVID, a lot of things are in print, but with COVID, we're doing a lot more online, which has sort of opened up this world for folks that could access it before. And then just in case anyone's interested in UNCRPD, Article 9 deals with accessibility and access to information. So lack of access to health information violates that article. And I should say it goes beyond, I've given print forms as a concrete example here, but it goes beyond that. If you think about even your own televisions, if you've been watching, or maybe you do it on the computer now because you're all, I'm sure, young millennials, but if you do it on the computer, you're probably watching the daily briefs that Doug Ford gives. Maybe you watch the numbers for COVID, and how many times have you seen a sign language interpreter? So just kind of reflect on that and think about how that might be a barrier for folks. Or how many times have you thought, wow, they're not speaking in language I understand, this is medical speak. So think about plain language being language that's simple and clear and easy to understand. So if you think about those kinds of information barriers, even in our own lives, that they're pretty prevalent. But there are definitely solutions. I talked about forms. Really cool solution here is where printed pamphlets are available in clinics. And again, this might be pre-COVID. You can have a really cool thing called a QR code. So you just take your phone and you scan it, and then you've got access to the information. And I would say even in our COVID world, making sure that pamphlets and posters that are put up online, any pictures are captioned. So again, with COVID, we see a lot of graphs. We see a lot of pictures showing us how to put on a mask. I didn't actually know, this is something I'm very willing to talk about, how to put on a mask or do the sanitizing of the hands properly until someone showed me, because it's all pictures. So if you think about in the early days, all those memes and pictures that were out showing us how to keep our mask on, put it on, take it off, put the gloves on, do the Purell, that was mostly pictures. There was no audio described YouTube video that kind of walked someone through. So that's another cool solution where there's YouTube videos that show you how to do all these things, having audio description. So that just means a voice that's narrating what's happening on the screen. So it would say exactly what's visually being on the screen. And also, like I said, having medical info in plain language, not just for people with disabilities, but COVID is a stressful time. So we want things to be clean, we want them to be clear, easy to understand. So thinking about plain language as something that can benefit everybody. So we kind of touched on transit a few minutes ago as a barrier, but it's a barrier because of a couple of factors. And again, this goes back to a policy barrier. So some patients use, or some clients of services may use something called paratransit, which is a transportation system that it's for people with disabilities, and it has to be booked in advance, and your pickup and your drop-off time is pre-scheduled and generally can't be changed. So that's a challenge or a barrier, because if you're going to a clinic or you're going to receive support in the community and your time runs over, you can miss your transit, and that leaves you stranded or having to pay for a taxi. And for some folks, that taxi cost is quite prohibitive, mainly because the Ontario Disability Support Pension that people with disabilities who don't work receive is only $1,100-ish a month. So there's not a lot of extra room for taxis. So again, that's kind of an example of where there's a transportation barrier, but it's a policy barrier. So there needs to be more flexibility around transportation. There needs to be more accessible transportation that's mainstream, so people aren't having to rely on quote unquote special transportation for people with disabilities. But also then we get into economic parity and ensuring that people with disabilities are paid for. So that's kind of a nice wraparound barrier there that brings in lots of different levels of barriers. I would say a micro, so within the individual having to book their transit, a meso, so that's where the individual and the environment interact. So that's kind of the policy of the no flexibility around drop off and pickup. But then the macro around, well, what are we doing as a bigger sort of structural? How do we look at it in terms of how can we have transit that's inclusive and accessible for everyone, so we're not segregating people out onto specific types of transit. But there are some really cool services that I wanted to point out. So Red Cross actually offers a medical transportation system. So it is a system where a patient can be picked up, brought to an appointment by a volunteer, and then when it's done, brought back home. So informing patients of that, and again, informing clients of that. So for those of you going into healthcare, social services could mean the difference between someone accessing treatment or not. Because again, we talked about how much people make if they're not working, and it's not a lot. So there's a lot of sort of things to consider, layers to consider when going out into the community. I'm using kind of health and social services today because that's what our talk's about, but it's really about more than that. It's about going out to work and shopping and visiting with friends and school. So there's lots of reasons why transportation is a barrier. I'm just kind of using healthcare as the example today. There's a really great Uber option. I believe it's just in the States. It's Uber Medical Transportation. So a healthcare or social service agency can actually book an Uber for a client. So the Uber would come to the home, pick the person up, take them to the appointment, and then when the appointment's done, the provider could book the Uber to go back home. So it's Uber Medical, and it's, I believe, only in the States right now, but a really cool thing to sort of maybe read up on if you're thinking about solutions to how to get people to equitably access services. And again, this could not just be used in healthcare, maybe food banks or maybe community drop-in centers. So some great solutions there. So wayfinding, I don't know about you, but I find that big hospitals can be tricky even at the best of times, but signs are often in small print. And there's often an assumption when people go to a hospital, especially if they live with a disability, that they're going to have someone with them. And sometimes that's true, and sometimes it's not. So we want to make sure that people are supported either way. So if they come with a support person, especially during COVID, that person is able to safely be with them to support in any advocacy during the appointment or any communication needs during the appointment. But if a person does come alone, that they have the support they need. So really cool wayfinding and tactile solutions. There are, maybe you've seen them at York, because I know York has them, especially, I think I've seen them in the subway. So they're called wayfinding strips. They're strips that are put on the floor. And as you're walking, you can actually feel during the texture of the strip will change depending on which direction you're going. And then at the top of the steps, there are little textured bumps. So again, you'd know you're getting to some stairs. So that's some really cool tactile wayfinding technology. But there's also indoor GPS technology that can be installed in medical facilities and in community services and even at institutions like universities and colleges. So they are beacons where what happens is an individual would connect via a smartphone, and then what would happen is they'd be connected to a GPS indoors, and then they would be able to use their phone to help them navigate indoors. So again, that's a solution that works for some who have a smartphone, but again, that's where we need multiple to look at a barrier from multiple lenses, right? So that micro, meso, macro that I talked about, but also looking at different groups and what's going to work, because we know that not everybody has a cell phone.
Elizabeth, can I just jump in quickly?
Yep.
It just makes me remember last year a guest speaker came from the community farm next door to York, and they have this whole program to get good organic food out to the community because it's a food desert around York, sort of Jane Finch area. And one of the barriers was, so they had this partnership with Uber that you could get an Uber to the farm for like $2 or something to pick up your veggies and go home. But then they realized that like all these older folks didn't have a smartphone to get the Uber. So they're like, okay, so it's interesting, right? Because intersectionality is what allows us to think through all these barriers. Like, yeah, some folks that's going to enable them, but other folks are still not going to be able to. And so they were like, how can we do this? Should we? So I think they got like a big bike and they with one of those big carts on the front so they can cart veggies out that way. And then they were, you know, talking to community groups of where they could set up little veggie stands around the community because not everyone could get to the farm. So it just reminded me of that, this idea that we have to have multiple ways that we're imagining access.
Yeah.
Yeah.
And you know, that's a whole other lecture, but I love that example because it makes me think of technological oppression. So it makes me think about how, you know, it's easy for me to sit here and say, oh, well, there's, you know, Uber and there's wayfinding beacons because I have a cell phone and I have a laptop and I'm relatively digital literate, aside from the fact I can't get my Google Drive pop-up to go away. But aside from that small thing, generally I'm pretty confident with technology. But for lots of reasons, people don't have technology, they don't have access. So where technology can enable us, it can also disable us. And that's a really interesting thing to think about for folks that are doing any kind of virtual methods, right? The technological oppression piece, whose voices will be included or excluded when you're doing your virtual methods. So just a little tip for any honors thesis people in the crowd. Yeah, so, you know, we have talked a lot about the community and accessing the community and accessing healthcare. And at the beginning, I talked about number of community service hours. So there's been a shift to, I would say, starting in the 1970s into something called the independent living. Lots of services online. So in the 1970s, something called the independent living movement started. It's one of my favorite movements to talk about. So it started at UC Berkeley with Ed Roberts and the Rolling Quads. And they were a bunch of guys that just wanted to go to university, like you and me and Jessica. And what happened was they were told, yeah, you can come to Berkeley, but you have to live in the hospital. We don't have room for you in the residence. It's just not going to work. It's not accessible. The campus isn't accessible. You have to stay in the infirmary. So we think back to medical model, the students were seen as the problem. So Ed Roberts had polio and he had an iron lung, which is like a really, really big kind of tube that you have to be in most of the time. And he and his friends said, wait a minute, we're not living in a hospital. We want to get out and we want to live in residence and we want to make campus accessible. So they called themselves the Rolling Quads because overnight they worked to transform or work to sort of raise activism around getting curb cuts on campus and work towards being able to live in your residence. And on top of that, they sort of spearheaded in the disability rights world, this movement slowly out of hospitals and nursing homes and into the community. And Ed Roberts worked for a Center for Independent Living, which is a center that works with people with disabilities, for people with disabilities, to support community involvement and support independent living through this philosophy called the independent living philosophy. So I talk about all this because today we say, we being the policies that are in place to support people to live in the community will say, yeah, we want people to live age in place, but wait a minute, we see here patchworks of services, we see an adequate number of home care hours, and we see a recent CBC report of a 28-year-old living in a nursing home because there isn't enough accessible, affordable, safe housing alternatives for people, not just with disabilities, but for people who want to age in place and age in the community. So community-based home care does promote independence and it promotes well-being. So people may require assistance with daily living activities. So that could be housework, getting to appointments, meal prep, and the maximum number of hours provided by, used to be Community Care Access Center, now it's the LIN, is 4. And if you are a direct funding recipient, so you get money to fund your own care or support needs, then it would be 6 hours. So you can see that that's not really a whole lot of hours. And you also see in this list, and this is something that I find really interesting and I'm thinking about a lot in my PhD, and this is not an exhaustive list, but it's a pretty comprehensive list of the activities that in-home support services will support. So you're seeing kind of your ADLs, bathing, eating, going to appointments. Well, what about people that want to go to school? Yep, it is. That's right. What about people that want to go to work, and how do they get support at work if they need it with maybe personal care, setting up their computer? What about people that are at university on campus, like we all will be when COVID finally lifts in the after times, and need support on campus to set up their books or take notes? So we really kind of think about still community services in this narrow-ish scope. And what I like about direct funding is it allows you to be broad. So in direct funding, like I said, the user of services actually receives funding, and they hire and train and manage their own support attendants in their home to perform tasks that an individual may support. So availability of community services. So people with disabilities and their families have long advocated for more options. So that's kind of where I talked about direct funding. I talked a little bit about independent living movement. Those were some options that have been long advocated for. And including supports to allow them to remain independent. But unfortunately, support sort of shifted out of hospitals and long-term care homes without adequate supports, and without sort of really thinking beyond just the scope of activities of daily. And as a result, you can see this stat here, 18% of individuals under age 65 with physical disabilities still live in long-term care because of lack of options to live in the community. So whether that be accessible and affordable housing, enough home care hours, not enough family and friends to support informally, there's all kinds of reasons. So according to the Canadian Council on Social Development, only about 2/3 of individuals who need support are receiving it. And again, this is due to a number of factors. It can be due to geography. So it's one thing for us living in Toronto to request support. It's another if you're living in a remote, smaller community, or could be due to long wait lists. The other challenge is if you are living with a disability and you're living in a home with someone, sometimes it's assumed on the part of service agencies that you'll have that person be able to help with your support needs, and that's not always something you want or feel comfortable with. And women are less likely to get assistance than men. And the majority of help is provided informally by friends and family, and we'll talk a little bit about informal supports in a moment. And as a result of restrictions on supports and number of hours, individuals often have to choose which activities are quote unquote most important or most essential. So let's kind of unpack that for a minute. So you might be thinking, well, yeah, we all have to make choices, but I have read in the disability literature studies where participants interviewed have had to choose between having a shower or a home cooked meal because there was only a certain number of hours provided per day, or having to choose between going to bed really early or going to bed really late because there was no staff availability. So it sometimes is about restricting occupations, and then it can be oppressive because people aren't given choice and autonomy even though they're living in their own home. So I like this as an alternative. It does not work for everyone, and it's something that is, I would say, it takes a lot of creativity. So collectives of care, what are those? So I just talked about how agency-based care can be oppressive and doesn't meet the needs of users. And it affords state control over disabled bodies. So what do I mean when I say state control over disabled bodies? For those who have read any Foucault, you might have read about governmentality. But for those who haven't, what it means is, again, policies or agencies determining when and how somebody can do something. So the most extreme example would be in long-term care. You get up at a certain time when there's staff available, you all eat together when there's staff available, you generally go to bed at the same time, your activities are structured at the same time. So that's kind of state, quote unquote, control over the disabled body. It's also an example of what Goffman would call total institution, because there's not autonomy afforded for individuals to make choice. But in taking of collective care, it's really cool because it can be seen as a site of survival and flourishing, and it exposes oppressive ideologies. So an example of collectives of care could be things like L'Arche. So L'Arche is a community where individuals with intellectual disabilities live in homes with families who have agreed to provide support to individuals who need perhaps help with activities of daily living, but it's a family setup. So an individual might live in a home with a family and be out during the day working or volunteering, and then come home in the evening and be a part of that family. So it's an example of where it's more of a community-based model of support. Another example is Camp Hill communities, where, again, when Camp Hill started, the idea was that individuals would live with disabilities would live in a home with families or with individuals, perhaps a couple that had retired and decided it might be nice to have someone back in the house and not be an empty nester. And the idea, again, being that it was more of sort of a family setup or a collective. I've seen other collectives like co-ops where individuals with disabilities get together and live in a co-op setting, and together hire and train and manage their own staff in the co-op, because that way there's more of a community feel. So there's different ways that collectives of care can work. It's very grassroots, and it's something that's still, I would say, not very commonplace in terms of arranging supports for people and with people who require supports. And it's a framework to keep people who are marginalized safe when state interventions fail or don't work or cause harm. And we can see lots of examples of how state interventions have in the past caused harm when we think about certainly mental health and how people were treated in that context.
And sorry, just to jump in here, because we're thinking about intersectionality throughout this course of how that looks different on different bodies, right? So a racialized disabled body is not going to be safe in the way that a white disabled body would be. So that idea that collectives of care rise up around basically survival, right? Like in, one way it sounds very beautiful, and in another way it's like, well, that's the only way some folks can actually access safe care. So yeah, I think it's just an interesting way to think about care outside of the state, because the state is so unsafe for so many people.
Yeah, and I think that's a really good point about safe care. It's difficult to talk about, but there's lots of literature around individuals with disabilities, and we've certainly seen it in long-term care during COVID, who have not received safe care or appropriate care. And I think that these collectives of care have sort of arisen out of that, which is, you're right, in some ways kind of sad, and in some ways you want it to be this really beautiful community collective, but it's kind of arisen out of this need for, hey, we need to work to an alternative that's not oppressive. And I think the intersectionality piece is really important too, because for somebody with a disability who is LGBTQ and maybe is feeling unsafe receiving care from a specific gender, I suppose, that's going to look very different from someone who isn't. And so I think there's all kinds of things that come out of this collective of care and the conversation around what safe care looks like, which leads really well into the disability appropriate supports. So Kaiser Permanente has developed some guidelines for what disability appropriate and disability specific care looks like. So I don't know that I agree with the first one because they say using person first language. So if we go back to our models that we spoke about at the beginning, I see that person first is great. And perhaps in an affirmative lens, you might say, yeah, I'm a person first. But social model would say, well, the environment's disabling me. So I'm a disabled person because I can't access my environment, whatever that environment is. So although one of the guidelines here says use person first language, I would tweak it and say, ask the person how they'd like to be referred to. Do you want to be referred to as a disabled person, a person with a disability? We never say the disabled. We don't group a community like that. So that's a no-no, but I would say always ask the person or ATP. Considering the person with a disability to be their expert in their own support needs, their own care, and their own journey. And again, going back to the medical model, the medical model would kind of state that the professional is the expert. The therapist is the expert. There needs to be an intervention or a treatment plan, and the social, and certainly over going all the way across or continuing to the rights-based model would say, well, hey, wait a minute, we're the expert and we have a right to decide on our own support needs and a right to make good decisions and bad decisions and to take that dignity of risk. And I think I did send an article around dignity of risk out to Jessica, so I'm sure that if for those who want to read it, it's up there. And I would encourage you to read it because it raises some really interesting questions about being an expert in your own life and being valued to make the decisions that are right for you. So considering the nature of the disability and identifying yourself and addressing the person with a disability directly. This one's really important. I can't tell you how many interactions I've had where I will be with somebody and the person that is talking to the person I'm with, not me. So if I'm at, say, a medical appointment, the doctor, nurse, whomever would talk to the person I'm with. So addressing the person directly. And I think this is even more important. It's always important, but it's even more important if there is a communication barrier to still ask the person directly, how can I best communicate with you, as opposed to communicating with the support person or attendant, unless that's what you're asked to do, in which case that would be fine. So not making assumptions. We kind of talked about that earlier with the attitudes and myths and misconceptions. So it's easy to make assumptions around whether somebody's capable of working or going to school. Maybe some of you are planning to go into OT or social work or education, but just trying not to make assumptions based on pre-understandings of disability, but really getting to know the person and what their abilities are and how they might do things differently. And letting with the disability ask for assistance when it's needed. And sometimes this is a tricky one because we all are human and want to jump in and help, right? We don't want to see someone struggling and we don't want to see someone that's sort of bumbling along, but sometimes people just need a few minutes to do things a little bit differently or figure things out. And that's totally okay. And it sometimes makes us feel uncomfortable, but that's our own discomfort and we have to be reflexive and reflective about that and work through that and not put that on. So I like this last one, allowing sufficient time for tasks. So this is really back to dignity. So, you know, especially if you are supporting somebody in their home or you're working with a family and you're supporting the family who has a family member with a disability, this is really important to just remember that, you know, people take, everyone's journey is different. Perfect example, I might take longer to look something up on the computer because I use a screen reader. So if you were supporting me, you might say, I'll just give you a minute. What you're going to look for on the screen is the word York University login, and then I would go look for that. But it might take me longer, and that's okay. It doesn't mean it's bad, it's just different. So we kind of touched on ableism, although we didn't talk about it, but it's a belief system that favors normative, able-bodied standards, and it perceives people with disabilities of less respect and are worthy of less respect. And it kind of perceives the individuals with disabilities as less worthy of consideration. So sometimes ableism is tricky because it's sort of this really covert belief system. It's hard to pin. So you can think about sometimes comments that are made that might seem ableist. Policies can be ableist. So an ableist policy might be a policy that says, if you're receiving Ontario Disability Support Pension and you are living with someone and you get married, you lose your pension and they have to support you. That's an ableist policy because it doesn't promote autonomy of the person with a disability. So policies can be ableist, procedures can be ableist. It can result in public stigma. You probably can think of policies at York that are ableist, maybe things around compassionate leave, academic extensions. Maybe you're a student with a disability and the exam time that you're accommodated to receive is based on sort of a normative standard of what somebody without any disability would take to complete that exam. So there are all kinds of examples of ableist policies. Certainly in healthcare, policies that sort of favor the medical professional or rehabilitation professional experience over the disabled lived experience are certainly ableist. So there's lots of ways that policies can be ableist. Ableist comments could be things like, well, are you able to work because of your disability? Or downright saying things like you wouldn't be able to complete a PhD because you have a disability. So those are, again, based on negative attitudes and beliefs that we talked about earlier. So institutional ableism is the idea that institutions or policies can perpetrate ableism. So it can be things like, I mentioned the example with ODSP. Institutional ableism could be policies that this isn't allowed anymore, but would pay people with intellectual disabilities less than minimum wage. So they were called sheltered workshops. So it's a belief system that, well, we don't really value you, so we're going to pay you way below minimum wage because you don't really need to make money anyway because somebody's taking care of you. So it's sort of steeped in a custodial tradition. Rather than an empowering or emancipatory one. And it, even in the community services examples I gave, it's evident that people with disabilities continue to struggle to receive community supports and economic parity. So economic parity is being on par economically with able-bodied counterparts. So that's kind of institutional ableism, the idea that these things can exist within an individual, but also at a policy level. So looking at ableism sort of more broadly and intersectionally too, right? So some policies can discriminate against certain groups. So you think about perhaps the idea of a community center and where it's located. If it's not located near public transit, who's that going to exclude? Or even maybe you think about things in your own university that are inclusive to one group but exclusive to another group. So those are kind of examples of institutional ableism. So what can we do? How can we shift the culture? Because we always want to come back to solutions, not just barriers. So I really like this one. So this is really providing education. Nothing about us without us. So that's kind of really based on an emancipatory paradigm. So being the idea that individuals with disabilities are the expert. Research should be done in collaboration, consultation with people with disabilities, not about us, without consulting us. Research should be done with an aim to change oppressive structures and to empower individuals to want to make change within their communities and to really be able to expose structures that could be seen as favoring normative standards of able-bodiedness. So this one here is great around educating. So We need more faculty in all programs, but certainly programs where individuals, clinicians are going to work with people with disabilities, we need more faculty with disabilities. So certainly there's some great work happening at U of T. They have panels that come in and speak to med students. I've been on them in the past, where individuals with disabilities will come in. They will speak about their experience, what the barriers have been, how those barriers were navigated. Certainly, we need more disabled voices at policy tables, and you'll see my question here at the end. So it's great to have policies, but who's developing those policies? What kind of hegemonic understanding was embedded in those policies? So, you know, if we have a policy that says, for example, or a directive that says, well, you can't receive social assistance if you're living with somebody who's working, what values are underpinned by that, and thinking about why are those values allowed to be predominant. So that's kind of what the question is I leave you with. If you think about, you know, any kind of leadership roles, how often do we see policies that are about or for the disability community, and you can extend it to other communities, made by and with people from those communities? I would say it's starting to happen, but I think it has a long, long way to go for it to continue to flourish and be where it needs to be. So these are just our references here. So at this point, I think I will stop and allow people to have your 5-minute break, because we've been going for about an hour, and then we'll come back and we'll have some Q&A time, and we can certainly talk through anything. There was lots in there, and I'm happy to unpack anything further.
Perfect. Thanks, Elizabeth. So why doesn't we just take a few minutes, 5 minutes, and then we'll come back together at 3:34.
No problem. I'm glad you could come too. Just chatting.
Yeah. Thanks, Rashida. Good luck.
Share. There we go.
Thank you, Elizabeth.
No worries.
Okay, we'll come back in a couple minutes.
Yep.
I'll write it in here. I'll just pull a couple questions that that were in the chat, Elizabeth. I'll just queue them up in the chat again. I'm on mute. Okay, we're back. It's 3:34. So I suggest we start. Elizabeth, could you see those questions or read those questions that I threw in the chat?
I could, yes.
I could start reading them out, and then we could just move into wherever the conversation is going to take us.
Yeah, absolutely.
Okay, so the first one was Nicole asked at the beginning, if you could just talk a bit more about this difference between impairment and disability.
Yeah, so impairment is sort of more of a functional thing. So it looks at something again within the body. So an impairment could be hearing impairment, a visual impairment, but it really looks at it sort of medicalized within the body. Whereas a disability can be more broad. It certainly can be seen as something within an individual, but disabling factors can exist within policies, environments. They can exist sort of at all levels, like we talked about. So that's sort of the key difference between those two.
And can I just follow up to say, Elizabeth, I think too, how I like to talk about it is this idea that impairment is natural. We can have non-natural created impairment. So if you think about like war creates a lot of impairment, environmental kind of destruction can create impairment, but impairment is totally natural across time, space, every culture, every race. Just impairment has always been part of the human experience, whereas disability is what we create on top of specific bodies. And that also looks different across time and space. So an example often to really get at that point is this idea that mental sort of health or wellness looks different in different cultures. So in South America, folks who hear voices, can talk to the other world, are shaman who are very respected, who are seen as elders in a community, that guide a community, that hold knowledge, that are held up as people who guide their entire community. Whereas someone who lives with that same type of different mind in our culture would be labeled as having maybe schizophrenia and, removed, not able to work, institutionalized, all those kinds of interventions that can happen on that body. And so it's sort of the same impairment, but looks very different based on where they live because of the way that we have built disability around different bodies.
Yeah.
Does that make sense, Elizabeth?
And I think also different attitudes too, right? And how that, two people could live with the same impairment, but if, again, thinking about our affirmative model, if their attitude towards disability is quite different, or their family has a very different outlook, or their community, that's going to impact how they interact with the environment as well.
For sure. And access to privilege too, right? If you have access to, private supports and not having to rely on the state, all those kinds of things, which all is wrapped up in that kind of disablement piece. So yeah, but they're not mutually exclusive, but we can, to try to sort of say this is kind of the way that we construct one or the other, and that there's a very natural piece around impairment, which is like Elizabeth said, started out, I think in your lecture, Elizabeth was just talking about this idea that it's a characteristic like every other characteristic. It's universalized by society, but it's just one piece of people. So the second one was, and Rashida had to go, but I think you addressed it about stopgap. Is it mandatory?
Yeah, so stopgap's not mandatory. It's a great organization. Luke Anderson's fantastic. He's been on TV several times. You could YouTube him if you're really interested. What I love is it's exactly what it sounds like, a stopgap. The reality is we talk about all these barriers, but it's expensive to retrofit a building that's really, really old or doesn't have, like, especially if you're a small business, right? It's not cheap. So I love what Luke Anderson's doing, because he's saying, hey, we know it's expensive. We get that. So we're going to provide, and there's tons of this examples of stopgap in Roncesvalles, which is near the community that I live in, or part of Toronto that I live in. And what I love is it's old pubs that never would be accessible, but with a wooden ramp, it's at least a step in the right direction of being accessible.
Thanks. And then the third one is, you mentioned that in the piece around support, sort of care in the community, that women receive more care than men do. So there's like a gendered piece there. And if you could just explain that.
Yeah, I actually think I'd have to look back at the slide, but I think what is it was 2/3 of people that need care receive it. And I think what I said was women are less likely to receive it. And I think that's because generally women are seen as traditionally the ones providing care. So either um, perhaps there's a tendency for women not to reach out because they feel like they should be providing care, or perhaps it's just yeah, I'm not sure why that could be, but I think it could be definitely gendered for sure.
Okay, thanks. So we'll open the floor for questions if you want to unmute yourself, or you can write it here in the chat. And in the spirit of what Elizabeth shared on one of the slides about giving time and everyone, that was one of the things that I definitely started to think about as we moved to remote teaching, was like giving people space and silence. I can feel uncomfortable with it. We just all sit here awkwardly staring, or, sitting here thinking, okay, what's happening? But yeah, so if you have any questions, Elizabeth is happy to answer them. Or you could send them in a private message to Elizabeth.
Me, if you wanted, and
Yeah.
certainly my email is there too. So you could certainly email if you wanted.
I have a question. I find very often when I hear conversations in organizations or programs about accessibility and so on, very often they'll focus on one type of accessibility. So they'll discussing mobility related issues, or ways to make text available for folks with visual impairment. But do you have any sort of thoughts on how organizations should go about having those conversations in a more broad way? Like, I think sometimes there's a tendency to think, well, we addressed this one type of accessibility problem, pat on the back, we did it, guys.
Yeah, for sure. I think that's where the intersectional lens really is helpful, right? Because, and we talked about this, what's going to work for one may not work for another person. And so having flexibility. So, absolutely. We talked about technology, perfect example. So if we say, oh, well, give everyone technology, it'll make everything easier. They can get to appointments, they can have virtual visits. Wait a minute, what about people that don't have technology, or that don't feel confident and comfortable using it, or that can't afford a monthly internet? So I remember when COVID started, there was a lot of conversations around technological oppression, because on the one hand, isn't this great? Church is coming to us. So for those people who found it physically difficult to get into a church building that might be old and not have an elevator, or perhaps people that didn't feel comfortable going outside in the winter, this is so great. Church is coming to us, classes are coming to us, groceries, everything's coming to us. It's so great. And then, whoa, pause. What about people that are spending days alone because they're immunocompromised, they're isolated, and they don't have Zoom, they don't have a laptop with Zoom and the internet, high-speed internet, to pop onto Zoom and have happy hour with friends or to have a church service? So I think your point's really valid, especially during COVID, because I think what's happening now is we're so trying to focus on how can we implement solutions that are going to keep people healthy and safe, but also address mental wellness. And so people, I think, that I've worked with, especially when COVID first started, it was very easy to jump to technology as the only solution. So what else can we do? Can we do virtual phone visits? Can we send packages to people that aren't able to sort of pop onto a Zoom meeting? Can we have a laptop donation program? What about the library, which has a really cool hotspot program where you get a little, kind of like a USB stick, and you plug it in and it gives you Wi-Fi. It's through the Toronto Public Library. I don't know how fast it is, but it would certainly at least allow people to connect. So those are kind of some really concrete ways that you're right. Providing access to one isn't going to provide access to all.
Yeah, and just to follow up on that, Elizabeth, I think I really like this idea around asking people for their access needs. So
Yeah.
moving away from this idea of kind of accommodations, like institutions use that kind of language, but disability kind of justice folks are really talking about this idea around access needs. We have different access needs, right? And that's totally okay. It's not like accommodating something special or, you know, sort of segregating that. It's this idea that what do you need to access this space, right? And so it's asking folks what access needs. So, and any kind of disability, you know, event or talk or anything, that's the language that we hear. The language is, what are your access needs? What do you need? That might be TTC tokens, right? Because poverty and disability intersect. So it's so much deeper than, you know, yeah, just curb cuts and things like that. It's, you know, childcare, it's TTC tokens, it's food at meetings, it's all these kinds of things. So this idea that one, yes, who's involved in these conversations, and how are we compensating people for these conversations? So there's often an onus on marginalized folks to give their labor for free, right? So an organization will be like, you know, we want to know, how can we be more accessible? Can we ask you some questions? Can you come in and give us some kind of thing? Well, yeah, but pay them, right? Like, yes, you know, to have a workshop with a disabled person talking about access, right? Like I think that's the kind of thing where we need to constantly be pushing the conversation is, who should be doing this labor? I've been doing lots of reading on kind of anti-racist trainings and who needs to be doing that. Like lots of white folks are doing that work. And so lots of, you know, racialized folks who are doing this work saying like, pay us to do the work, pay us to come in and do it, right? We should be doing this work, but paid, not unpaid. So I think those are all kinds of things that we should think about when we have these conversations.
I think that that's a really good point, and it kind of brings me back to the goal or the idea around emancipatory research. Like, you want people to be involved in research that affects that community or that group, but you want to do it in a way that's respectful. So whether it's paying people, whether that's giving people knowledge and tools and skills so that they can perhaps build on that to help their own career, whether that's food at a meeting, childcare, whether that's options about how people participate. I think it's all really, really important. And I think I love what you said about, you know, the idea of tokens and poverty and disability intersecting, because I think, again, thinking even now with COVID, this idea that, oh, well, you know, we'll have food baskets and people can come pick them up who have maybe lost their jobs, or people who have a disability and aren't able to afford food. But what if I can't get to the food basket? Or what if the food basket is brought to me, but I'm somebody with a physical disability and I don't have enough hours for someone to chop and prepare all that food? So you're right, thinking intersectionally in and outside of disability and how that intersects with other forms of oppression, but also intersecting disability. So lots of different ways to think about it for sure.
Just a question I wanted to ask, and a little unsure how to phrase it properly, kind of trying to make sense of it in my head.
Okay.
But I work with, or in the past, I've worked with bringing like massage therapy students to different community sort of like programs to provide those services to the people living with various disabilities. And I know one of the concerns going back now, I teach in a program at Humber, and one of the concerns is our off-campus internships are going to be pretty much non-existent, because a lot of these facilities aren't comfortable, or we can't make it accessible for the students to go in. And I find just in working with these different programs for the past couple of years that they are often relying on these type of programs, but it's often relying on volunteer work. And to Professor Vorstman's point, you know, I feel like it sometimes works the other way too, where there's such a reliance on it being volunteer work that the initiative isn't necessarily there for people to branch into these fields, because it's like, well, this field doesn't pay. So I wonder if there are any initiatives, or what your thoughts would be to that sector of things, because I mean, this is often the case with these types of the positions that are so desperately needed are often unpaid and volunteer positions that people are sort of dissuaded from going into for that reason.
I think that's a really interesting point, because it reminds me of like ethics of care and how care work, and care work can be broadly defined as unpaid. So Eva Kate does some really, really good work and writing around ethics of care and how do we see care as something reciprocal that we both give and receive, and how as a society do we do that in a way that facilitates recognition of labor that's unpaid and frankly not well paid when it is paid. And we know that from looking at all of the wage increases that we've seen with PSWs. And so it's about what work we value. So I talked about hegemony earlier, and the idea that what are the ideas or the things that we value as a society. And care work, unfortunately, does not receive the value that it really needs to receive. And so I don't know of initiatives, but I would recommend Eva Kate as a scholar that you might want to kind of spend some time looking at.
Yeah, Christopher, I think that's so interesting. This idea that, I mean, it's very dangerous with neoliberalism has been this idea that we can just, everything is downloaded on us from the state. And so, there's this beautiful piece that Elizabeth talked about, collectives of care. That's, we're humans. We want to be in relationship with each other. We want to care for each other. Yes. But the other side of that is that the state should be doing that labor, right? So we see this in the global South, across the global South, is that there's not a functioning social safety net, right? So folks have to rely on family members to take care of them. And there is a beautiful side to that, of course, but there's also a side to that, which means that folks then are dependent on other folks, whether they want to or not. And so I think you're highlighting this interesting issue here, which is, it's great. It's giving these, certain students these kind of, opportunities, but they're unpaid, and then organizations end up relying on that because they get such small funding from the government, so it's trying to go towards other things. So great, we've got some massage therapy students that are going to come in and do this. We have other folks donating this kind of stuff. So I think it's dangerous, and the answer to it is literally defunding the police, and then we can put money back in social services. Like, the answer is yes, there's some interesting kind of community collective stuff going on, which is very interesting and it works for certain folks. But I think on a large scale, we need to push for government reform in those areas. So I just got a call yesterday from the NDP saying, have you heard about, Jamit Singh talking about the new thing around long-term care and how basically we need to get it back in state control. So we know where the deaths happened. They happened predominantly from COVID in privatized long-term care facilities. And so the idea is when we move things back to the state and properly fund them, then initiatives like you're talking about, Christopher, are good, but they're just small, right? So it's just, an extra, okay, you can have a couple of, sort of different volunteer experiences. The problem is when that becomes the essential piece of an organization's way that they're meeting people's needs. So it speaks to everything Elizabeth was talking about, unmet needs. What does that result in? It results in the fact people can't get massage therapy enough, they can't get physio enough, and then they end up in the hospital. So I think the difficult answer is that we need to strive for things like, defunding the police so we can put money back in social services. We need to strive for electing different governments that are going to put priority back in where we need to care for folks, right? Like, we've talked a lot about that over this course, is this idea that we're not doing care in our healthcare system, right? Zoe talked about at the beginning as uncare. We're doing uncare to people. We're not caring for them. So I think it's difficult because it comes back to structural problems. Like, Elizabeth, you brought up really interesting things like the wayfinding. There's all kinds of neat things we can do, but those all need to still happen within the larger structural piece. Because unless we're doing that larger structural piece, we're going further down the road that you're talking about, Christopher, which is not working for folks, right? And we know it's not. Our system is massive and expensive, and it's still not caring for people. So it's not about, it's about where we're putting resources, who we're prioritizing. And then, as Elizabeth said, it's who we're putting at tables. So if we had disabled folks at policymaking tables, they wouldn't make shitty policy. They would make good policy that worked for them. They would talk about how many hours you need to have a real life in terms of care in your home. So yeah, I think that's so interesting because some of my work is in international experiential learning, where we send students from the north to the south. And so I think about all those kind of problems in that context too. So that was an interesting question. Thank you.
Thank you.
And I just wanted to get a sense, because I've used the word a couple times. Do folks know just really basic what hegemony means, or understand like how that relates to policy? So hegemony is basically the dominant discourse and how that shapes power. So the dominant ideas and discourse are used to shape power. So certainly media is an example of how hegemonic norms are shaped. So if we take an example like your mental health example is quite a common one. So think about historically how mental health has been shaped in media, everything from movies like One Flew Over the Cuckoo's Nest to Rain Man. They don't portray mental wellness and mental health challenges in a very favorable light. And certainly we can see dominant ideas around mental health over centuries in terms of how people were treated. And you can look at Foucault's A History of Madness, there's tons of texts. So that's kind of the idea of hegemony. It's the dominant discourse that shapes policy and shapes ideas around policy.
Thanks, Elizabeth.
Yeah.
So there's another question in the chat. Nicole says, I'm curious about how you see changes related to COVID affecting accessibility of healthcare. So, you know, positives, negatives. I think you highlighted some of the positives, but if you could speak directly to that.
Yeah, so definitely positives, you know, around, I think one thing COVID's done, for better or for worse, it's raised awareness about long-term care, about older adults, about people with disabilities, although that's taken a while, and certainly about even people of color, and the fact that we talked in the early days about, well, you know, we shouldn't be taking transit. Well, lots of people need transit to get to work, and it's not a luxury, it's a necessity. And so again, whose voices were privileged in decisions to cut transit routes. So I think it's raised a lot of awareness. And I think the other thing about COVID is it's kind of forced us to be creative about what solutions we can and cannot offer. I guess my hope out of COVID, because it hasn't felt this way, especially when we look at, and I'm happy to say it was just rescinded, but March 28th, the Bioethics Roundtable put out an optional, a triage protocol that was to be used by healthcare providers if there was to be a second wave and a shortage of ventilators. And one of the determining factors for who would not receive a ventilator was the clinical frailty scale. So if you were frail, or basically if you had any number of medical conditions, you would not be eligible. So again, I think that a lot of communities got together and were pretty vocal about why that was ableist and ableist policy. And so awareness and consciousness raising was sort of done through that work. So I think COVID's been really good at exposing some things we've known are wrong for a long time, but I think COVID's helped us to see that they're really wrong.
Yeah, I think, Elizabeth, it's interesting because I think what COVID's really done is it hasn't taught communities who have been oppressed anything. Like everyone's like, yeah, we've been living this for a really long time. It's literally just told folks with privilege, like this is actually folks' reality. So it's interesting because so many people are like, whoa, you know, there's just so much talk about like racism now. It's like, people are like, yeah, people have been having that conversation forever. Welcome. So I think, yeah, COVID's really brought to the forefront all of these things and pushed it kind of far and into everyone's consciousness now, where many folks have been living it for a really long time. But now sort of, folks with privilege are forced to kind of think about and reckon with what we've created, the society that we have designed. Yeah.
For sure. Any other questions or comments? I definitely encourage everyone, especially those interested in career and social services, but even those who aren't, to read the article, the Dignity of Risk article. It talks about really cool alternatives to completely removing decision making. So it talks about just things like supported decision making. It talks a little bit about how assessments for consent and capacity can be ableist. It's I think really helpful. It's not a super heavy read, so I encourage you to look at that. And certainly, you know, at any point, folks can reach out on email if they have more questions or things that you want to keep chatting about.
Thanks, Elizabeth. And so for this course, they're going to write a paper on a health kind of inequity piece and then take the lens of intersectionality and look at what that health inequity piece looks like from lived experience from a specific group. So there was all kinds of things in this lecture where you could pull out and really get into sort of on each slide. There was a few of them. So I encourage you to go through, and then Elizabeth's already done some research there for you. It's at the end of the slideshow.
Yep.
So there's all kinds of pieces, and you were you know, great at highlighting those, Elizabeth. And then the last piece of the they're going to talk about an intervention that could intervene in that problem that needs to come from the community. So again, you've brought up all kinds of pieces that folks in the disability community have been asking for. So yeah, there's all kinds of things. If you're interested in writing in this area, you know, start with Elizabeth's presentation and kind of go through it and see what speaks to you, where you want to push further.
Absolutely. And, you know, I'm happy if folks want to, like, I'm not going to write or edit your paper, but if you want to wing an idea by me, I'm happy to do an email chat about that, as long as that's okay with Dr. V. But yeah, absolutely. If folks want to ask a question like, hey, you mentioned this, but could you clarify? I'm thinking about doing my paper on this, for sure.
That's very generous of you, Elizabeth. Thank you. So we will wrap up for today. If you're in Toronto, maybe you can get outside for a little bit. We do have at 4:30, we do have tutorial, and it's going to be live again. Today is our big live day with the librarian. So bring your questions for your paper, because she's going to address basically that assignment. So if we can all say thank you to Elizabeth, you can write it in the chat. Thanks for spending this time with us. Thanks for being generous with all of your knowledge and your answers. Thank you.
You're welcome.
Thank you so much, Elizabeth.
You're welcome.
It was great. Thank you so much, everyone.
Thank you, everyone. See you all at 4:30.
No worries.